So just to bring it back to diabetes, because you'll recall that the science challenge included cancer, cardiovascular disease and obesity, but to focus it on diabetes for the purpose of today's discussion, I'll just want to give you some information, and I feel like I'm teaching you to suck eggs really, because if this audience doesn't know this stuff, then I don't know who would. But this just sets the scene as to what informed the science leadership team as to where we should focus our research. So this is the diabetes prevalence in New Zealand between 2005 on the left and 2015 on the right. So up the y-axis there is the percentage in the population that have diabetes, and across the bottom, and I apologise, the left thing's missing the age groups, but you'll see this is by decade across the bottom there. Now the striking things I want you to notice from this information is that, perhaps not surprisingly, diabetes becomes more common in the older populations. Now this is total diabetes in New Zealand, so it includes those with type 1 diabetes and type 2 diabetes, but we all know that type 2 diabetes overwhelms, in terms of the numbers of people, type 1 diabetes. The striking thing is the differences between ethnicities, and you can see there on the left-hand side that in the older age groups there is a gross difference between Maori, Pacific and Indian populations in terms of the prevalence of diabetes in that population compared to European, which is in the blue line at the bottom. Compare 2005 to 2015 and it doesn't take a genius to see what's happened. There's been an explosion of diabetes in New Zealand, and the differences between ethnicities have become further exaggerated, and also those curves, if you appreciate it, have been moved to the left. In other words, there are more people being diagnosed with diabetes at a much younger age. So we've got a huge problem in New Zealand, a huge problem with increasing numbers, younger age, and more disparities in terms of who's getting diabetes. But that's just the tip of the iceberg. So known diabetes is the bit of the iceberg we can see above the sea. Actually, we have an enormous problem with pre-diabetes in New Zealand. So that is the stage of diabetes when your blood sugars are not really terribly elevated, just a little bit high, but is the prelude, it's the warning, it's the early phases of developing diabetes. And 25% of our adult population have pre-diabetes. Now that's incredibly scary. 10% of those people each year go on to develop type 2 diabetes. And if you have pre-diabetes, your lifetime risk of getting type 2 diabetes is 70%. If you have pre-diabetes, you already have an increased risk of developing cardiovascular disease and dying prematurely. So this is a major, major problem. The next piece of information which informed the team was the knowledge from international studies, and this is just one example of numerous studies, which show that lifestyle change in people with pre-diabetes actually works. If you can achieve it, it actually works. So here you can see that those people in the green line here who were randomized in this trial, big trial in America, to intensive lifestyle modifications, so that meant both diet and activity modifications, after 4 years had almost 60% less risk of developing diabetes, going on to progress diabetes. A massive impact. The sort of thing is far bigger than many drugs, and indeed you can see there if people were just simply randomized to receiving metformin, actually, yes, that reduced their risk, but not nearly as much as actually making those really hard lifestyle changes. So it works, it's just really hard to do and really hard to achieve, and what we've found is that it's been really hard to actually translate that into the real world, the real population. So those are the three pieces of information which inform the science leadership team's approach to where we should be focusing our research. Increasing problem, increasing disparities between ethnicities, this huge population with pre-diabetes that if we don't do something about it is going to overwhelm the health system and the costs of the health system in New Zealand, and the knowledge that actually there are simple interventions that work, it's just that we can't get them to work in our population. So how do we go about doing that?